Yeah. Yes.
Okay, so today I will start. My name is Mahsa Zain Abdin, and I'm a fifth year medical student. Just one question. انتوا سامعين صوتي في صدى ولا لا؟
واضح مع صوتك.
تمام, okay. So today we will be discussing the platelet disorders. My part, to start with it, first of all, I need to explain to you what are the platelets. So as we know, starting from the bottom, the hematopoietic system in our body is composed of three main cells: the erythrocytes, which are the red blood cells, and they're concerned with the oxygen transport. Then we have the leukocytes, which play a very important role in our body defense against infections and tissue injury. And finally, we have the thrombocytes, which are the platelets, which are our main concern today. So basically, as we know, they're involved in the coagulation, in maintaining the integrity of the blood vessels, and preventing any blood loss. First of all, let's discuss how these platelets are formed. So the process of formation of these platelets is known as thrombopoiesis. It happens in the bone marrow. In the bone marrow, we have the hematopoietic stem cells. These hematopoietic stem cells are then divided into either myeloblasts or lymphoblasts. We are concerned with the myeloblasts because from the myeloblasts, we have differentiation of certain cells known as the megakaryoplasts. These megakaryoplasts, they're known as the earliest precursor of the platelets in the bone marrow. So if you have any question about the earliest precursor of the platelets, it is the megakaryoplast. It arises from the hematopoietic stem cell by a process of differentiation. So that's its definition. This megakaryoblast, it undergoes a process known as endoreplication. You need to know that this process, it doesn't happen in our body except for these types of cells, which are the megakaryoblast. It's a very unique process. What happens in endoreplication? Usually, it's a process for the nuclear chromatin. So as you can see, a process where the nucleus is dividing and not the cytoplasm. So only the nucleus is being divided over time. So in other words, there are no division of the cell. This will result in, as we can see here, something known as the promegakaryocytes. It is the promegakaryocytes, you can define it as a very, very large cell containing up to 32 times the normal diploid content of nuclear DNA that was in the megakaryoblast. And it is formed until once this is formed خلاص, there is no further nuclear replication. So the nuclear replication after this step ceases, and the cytoplasm, it begins to become more granular, as we will see in the megakaryocytes. Okay, so up till now we have the hematopoietic stem cell differentiate into myeloblast, which will differentiate into the megakaryoblast. Megakaryoblast, as we can see, it is the main precursor of the platelets. It undergoes a very specific type of replication known as reduplication into promegakaryocytes. Then from the promegakaryocytes, further differentiation occur, and we will have something known as the megakaryocyte. This is also a large cell. The only difference, as you can see here, is that the cytoplasm is abundant. It is light blue colored, and it is abundant with red purple granules. So every 4 to 16 nuclear lobes from the promegakaryocyte will be clumped together, as you can see here. They're clumped. And we will have the presence of the purple granules, the ones surrounding it. Then we have our platelets. So platelets, they are formed from the pseudopods of the megakaryocyte cytoplasm, which get detached into the bloodstream. So basically, pseudopods from the cytoplasm will form our platelets. We can say that the formation of the platelets from the stem cell is takes about 10 days. This is not the lifespan, but it is the formation. How long does it take to go through all this process? Another thing is that you can keep in mind that these megakaryocytes, as we said, it will form pseudopods. Each megakaryocyte, each one cell, we can form up to 4,000 platelets. So this is a side note, you can keep it. So now when we're going to the definition of the book, it defines a platelet as anucleate, because it doesn't have a nucleus, small cytoplasmic fragments derived from the megakaryocytes. They are involved in the coagulation by maintaining integrity of the blood vessels and preventing blood loss, as I said. The main action comes in the primary hemostasis, as we will discuss later on. Other information you need to know about the platelets is the granules. Like these granules that I explained, what are they? We have something known as the dense granules, others known as the alpha. For the dense granules, you can memorize the mnemonic cache. So C is for the calcium, A is for the ADP, S for the serotonin, and H is for the histamine. These are the types of the dense granules. Then we have the alpha granules. The alpha granules, from the word alpha, you have the word F. So all of its contents also have the word F. We have von Willebrand factor, we have fibrinogen, we have fibronectin, and platelet factor 4. So this is the only way you can remember them. Last point is about the platelets, the lifespan of the platelets. So when you spell the word platelets in the pronunciation, you're indirectly implying number 8. So you can remember that by saying that the platelets lifespan is from 8 to 10 days. Last thing, the platelets in our body, 70% of them are usually in the circulation, while only 30% are sequestrated in the spleen. Okay, I know this looks like a very crowded slide, but we can go step by step. The main function of the platelet, as we said, is hemostasis, which hemo means the blood and stasis means to stop. So our main aim is to stop the bleeding and thus seal the injured area. So for the steps of the hemostasis, we will go one by one. But in summary, we have vasoconstriction, then primary hemostasis, then secondary hemostasis, then clot stabilization and resorption. For the platelets, we will mainly focus on the first two steps, which is the vasoconstriction and the primary hemostasis. In the beginning, you have an injury, which is an endothelial damage. Once we have the endothelial is damaged, as you can see here, the endothelial, this is the site of injury, and the endothelial is damaged. The subendothelial collagen is exposed. The damaged endothelium will start also producing a substance known as endothelin that will also help in the vasoconstriction of the vessel. So our first step is the vasoconstriction. Why do we need vasoconstriction? Mainly to help reduce the area. So here, as you can see, due to this vasoconstriction, the area has been reduced, so to reduce the blood loss that is leaving the vessel. This is our main, or the first step. Okay, what happens next after this vasoconstriction occur? As I said, that the subendothelial, the collagen in the subendothelial is being exposed. So now the platelets will start to adhere to this exposed surface. But before the platelets, we have the von Willebrand factor. The von Willebrand factor, these red spots, they will come and they will line the area to help the further platelet adhesion and so on. So von Willebrand factor, it binds to the exposed collagen and it will help in the platelets. It acts as a bridge between the platelets and the subendothelial collagen. The platelets have two main functions here. We have something known as three main functions. We have the adhesion, activation, and the aggregation. Adhesion is something between the platelets themselves and the endothelium or the injured endothelium. So if this is the injured endothelium, as we can see here, the arrowed one, this is the injured endothelium. Adhesion is whenever these platelets are binded to the injured endothelium. Once they are bind, they then start to produce activating factors such as the ADP and many others I'll discuss now to call upon other platelets. Once other platelets come, they will bind to the main ones by aggregation, which is the second step. So we have two types of binding that occur, adhesion and aggregation. You need to differentiate them very well because the receptors differ. So as I said, the first step is the adhesion. The adhesion, it is, the platelets, they adhere to the collagen in the subendothelium. due to the presence of the receptors on the platelet surface. What are these receptors? The platelets, they can either have the GP1A and the GP1B. So these two receptors, it will help them to bind to the endothelium. And the adhesion to the vessel wall, it is further stabilized, as I said, with the help of the von Willebrand factor, which is the green triangles, as you can see here. يعني von Willebrand factor, it is considered as an adhesion glycoprotein. So it forms as a bridge between the collagen of the endothelium and the platelet themselves. Okay, now the platelets adhered. Once the platelet adhered, as I said, they will be activated, releasing certain markers, which is this step. Now we are in the activation. So some of the factors that these platelets release are the thromboxane A2, platelet-derived growth factor, ADP, thrombin, fibronectin, thrombospondin, lots of factors to help call upon other platelets in order to help them. So after the new platelets, these are the new platelets that will be coming. So the platelets come and they start to aggregate by adhering to one another. So forming these bonds. This process is mainly mediated by fibrinogen. As you can see here, this is fibrinogen. It forms the bridge between the adjacent platelets with the help of a glycoprotein receptor that is found on the platelets known as the GP2B3A. So up till now, we said that there are two important enzymes, GP1A2A and GP1B. These two receptors are important for the platelet adhesion into the endothelium layer. However, GP2B3A, it is a receptor that is important for the platelet aggregation along with the fibrinogen bridging. So the most important endogenous stimuli for the platelet aggregation are ADP and the thromboxane A2. So we can write here ADP plus thromboxane A2. These are the two important stimulators for this step, which is the platelet aggregation with the help of the GP2B3A. طيب, after this process, now as the platelets aggregate, as you can see here, تعملنا like a bridge. So this is the aggregation hemostatic plug, or known as the primary hemostatic plug. This plug is not stable and it is reversible. So after this step, it's not the end, it's just the beginning. Now we need to have the secondary, which will not be explained by me, it will be explained next week, including the coagulation cascade, where it will be activated by the proteolytic activity, and then fibrinogen will be cleaved into fibrin, which will form a fibrin meshwork, and so on. So in the coming steps, platelets are not much in use as much as the coagulation factors. So I hope everything is clear up till now. Before we move on, any questions regarding the hemostasis, primary hemostasis?
Yes, clear.
All right, okay. Here is just another figure explaining what I've said, like with the steps. So basically here we have the endothelial injury where the subendothelial collagen is exposed, as you can see, and then the adhesion occurs via the GP1B, and then activation happens producing ADP, and then finally the aggregation with the help of the fibrinogen and the GP2B3A. And the thing is that why we are still studying the hemostasis, because we have some disorders that happen in the hemostasis. As you can see through the steps, it started with vascular constriction, and then we have the platelets that are being consumed in the primary hemostasis. And as I said, in the secondary hemostasis, we'll have coagulation factors. So basically, we have disorders that can affect any of these steps. So for example, you can have vascular hemostatic disorders, you can have platelet disorders or coagulation disorders. So my part will be about the platelet disorders. So to start with the platelets disorder, first of all, we need to know that any disorder that happened to the platelets can either be due to a defect in the number or in the function. يعني it's either my platelets are very low, so they are not forming any clot, or they're not functioning well. If the platelets are very low, this is known as thrombocytopenia. Penia means very few amount. If the function is not working well, this is known as the thrombocythemia. I will not explain anything regarding thrombocythemia, but I just want you to know when we say that the function of the platelet is not working, an example for that is the Glanzmann thrombocythemia. As you can see here, this is mainly due to a deficiency in the glycoprotein 2b3a. So it is a problem in the function of the platelet where no aggregation happens due to a deficiency in the glycoprotein receptor. My part today will be about the platelet disorders due to the defects in the number. So if you think about causes that can lead to decreased platelet number, it can either إنه مثلا البون marrow is not working well, so I have decreased production of the platelets أصلا. This happens if I have bone marrow failure or bone marrow infiltration in leukemia disease. Another cause of the platelet thrombocytopenia, it could be due to increased destruction. Like this example, as I'll be explaining, the idiopathic thrombocytopenia purpura, and so on. So let's start with it. Idiopathic thrombocytopenia purpura has another name known as the immune thrombocytopenia because it's an autoimmune. So it's a disorder in which we have destruction of the peripheral platelets by immunoglobulin G autoantibodies. So as you can see in the picture down, what happens is that the spleen, it produces immunoglobulin G autoantibodies. They will bind to the platelets. We said that there is a platelet on the receptor known as 2b3a that helps in the platelet aggregation. So these antibodies, they bind to the glycoproteins 2b3a, and they target the complex for destruction in the spleen. That's why our platelets will be destructed, and clinically it will be present as a purpura. Let's go through the definition again. As I said, it's immunoglobulin G antibodies against our own platelets, forming a complex destroyed by the spleen. It is important to know that this type, ITP, it is the most common immunological disorder in women of childbearing age. Also, it is the most common cause of thrombocytopenia. Just 1 minute ago I told you there are many causes of thrombocytopenia. ممكن bone marrow failure, ممكن ITP, ممكن infection, ممكن SLE, ممكن DIC or TTP. But the most common of them is the ITP. طيب, let's talk about the clinical picture. How will the patient present to me? Most of the conditions, the patient have no symptoms, asymptomatic. He's often well. However, if it is very severe, it can result in general manifestations. طبعا manifestations of bleeding. Why? Because I don't have platelets. The bleeding can be in the form of skin bleeding. يعني مثلا petechiae or purpura. We're saying purpura. Maybe some of you don't know the exact definition of it. The purpura, it is a multiple spontaneous capillary bleeding in the skin due to defects in the platelets or in the wall of the vessel. So as you can see here, it is you can see it as spots, or any vascular purpura is palpable. If you touch it, you can feel little bumps. Okay, so this is if it affects the skin. It can have either it will present as purpura. طيب, the mucous membrane, we can either have gum bleeding when someone is brushing their teeth, their gums bleed a lot, or for example multiple epistaxis, lots of bleeding comes outside the nose. Also, the patient can bleed from any other orifices, like from the urethra. So we'll have hematuria every time he goes to urinate, he will have blood, or melena. And also easy bruising. Whenever someone hits you, you can easily be bruised because the capillaries bleed very fast. Okay, in severe cases of bleeding, the internal organs can be also affected. Like you can have cerebral or retinal hemorrhage, but I did not write it here because it doesn't usually happen with the ITP. Also keep in mind that ITP, since it's immune mediated, so of course it will be associated with other immune problems like SLE, systemic lupus erythematosus, HIV, lymphoma, leukemia, and so on. Okay, for the ITP, we need to know that it presents in one of the two forms. يا أما الpatient will come to me acutely, meaning that everything happened in less than 6 months, or chronic, more than that time. هون it's very important you need to memorize this in order to differentiate بالسيناريو whether it's acute or chronic. In acute, mainly those affected are the children. It's very rare you have an adult coming with an acute case. So the children aged from 2 to 6 years old, there is no gender discrepancy. So here in the acute, females ratio is equal to the males ratio, and the purpura is self-limiting. It doesn't need certain treatment or any intervention. Usually in the history, the patient or the child will have a viral infection previously, and the immunoglobulin levels, which is the A or the G, will be normal. However, comparing it to the chronic, it persisted for more than 6 months. It have remissions and relapses, it comes and goes. This affects the adults. In the adults, the females are more prone than the males. طبعا you can remember this because most of the immunological diseases happen in females more. So similarly, the ITP, because it's immune mediated, so it is affecting the females more. It's a fluctuating course, as I said, it comes and goes. وطبعا patient can have, as I explained previously, نفس الشيء, bleeding, purpura, epistaxis, and since she's a female, also she will be complaining of menorrhagia. Okay, and also because in this clinical scenario, the patient can have other autoimmune disorders. For example, 30 years old female with SLE, she came in complaining of bleeding and so on. You can think of ITP. In the chronic case, immunoglobulin A level can be less than normal because it's a very chronic, prolonged case. For the diagnosis, there is nothing very specific for the ITP. It is more of a diagnosis of exclusion. When you're solving a question, if it's not TTP, if it's not HIT, if it's not the others, then it's most probably ITP. The things that you can find is thrombocytopenia, of course. When we talk about the number-wise, so the platelets should be less than 150,000. And you need to keep in mind that all the other cell lines are normal. I have no problem with the red blood cells, white blood cells. It's only the platelets affected. You can have the anti-platelet antibody, as we said. We said in the immunoglobulin G. It is our main issue that is destructing our platelets. So we can have immunoglobulin G. We can detect it. But it's often present only in the chronic cases, 65% of the chronic cases. Regarding the PT, PTT, and the CT, all of them are normal, normal coagulation tests. The only thing that is prolonged is the bleeding time. If the patient got injured, he will tell you that the time of the bleeding is very prolonged. However, the coagulation markers are all normal. There is no problem with the coagulation because, again, ITP, it's affecting the primary hemostasis, not the secondary. It's affecting the platelets. Okay. If we did a bone marrow biopsy, and we usually don't do a biopsy except if the patient is very old, more than 60 years, so we will be afraid from cancerous causes, or it's an atypical case. If we did, we will find increased megakaryocytes that are trying to make up for the loss of the platelets. As in the treatment, as I said, in children, since it's acute, we just follow it, self-limiting, and we follow up for the fear of developing intracerebral hemorrhage, which is usually very rare. For adults, it depends. Is the platelet count less than 30,000 or more than 30,000? If the platelets is more than 30,000 and there is no any bleeding clinically, then no need for the treatment. If the platelets is less than 30,000 or there is a clinical significant bleeding, then I can give corticosteroids or IV immunoglobulin. Okay. Any questions regarding the ITP before we move on to the other one? Okay, no questions. For the thrombotic thrombocytopenia purpura, to define this disease, it's a deficiency of the von Willebrand factor cleaving enzyme. So basically, we have an enzyme known as ADAM-TS13. This enzyme, it usually cleaves the von Willebrand factor. So when we have a deficiency of this enzyme, the von Willebrand factor multimers will aggregate together and they will form microthrombi. This will block the small blood vessels فبصير في عندي end organ damage. Let me explain this from the pictures. Okay, so as we can see here, الADAM TS usually or normally it inhibits or it يعني helps in cleaving the von Willebrand factor. So whenever I have a deficiency in the ADAM-TS, so it's not working, so it's not cleaving the von Willebrand factor, so large multimers will aggregate, as you can see here. So it is aggregating. This will act as a microthrombus because, as you can see, this is the vessel. Let's assume that this is the vessel, okay? And this is the diameter of the vessel. Usually the blood should flow from all the areas, but because these aggregation are happening here, it will act like a blood clot. So the blood will only be moving from this side. So this will result in the end organ damage. The organs that are receiving very little blood, yani they will be damaged. Another thing is that the red blood cells that are moving. So normally this is the blood vessel, and this is the red blood cell. So the red blood cells, they normally move with no any problem. However, whenever we have this multiple aggregation, the red blood cell will hit it and it will be cut into two parts. The red blood cell حتصير له fragmentation or hemolysis. This is known as microangiopathic hemolytic anemia, where we have severe hemolytic anemia. And it will present in the blood smear as the schistocytes. So as you can see, the red blood cells, they're not circular, لا, they're cleaved off, as you can see. Okay. For this disease, thrombotic thrombocytopenia purpura, it is known as the classic pentad or the death triad. The death pentad. We have five main things or five main clinical manifestations that you will find them in the scenario. First of all, the fever. Then we have the thrombocytopenia, which is decreased platelets. And then we have the renal failure. Due to as a result of the end organ damage. Also we'll have neurological findings and the microangiopathic hemolytic anemia. For the neurological changes, it could be either delirium, seizures, decreased stroke, decreased consciousness, or can even lead to a stroke or vision loss. I think that's okay. Next, we have the hemolytic uremic syndrome. It is important to discuss it now because it overlaps with the thrombotic thrombocytopenia purpura. Both of them are a spectrum of the same disease because both of them have the same pathogenesis where they have ADAM TS13 deficiency. And this deficiency happens because it's either inherited or often acquired secondary to any of the infections. Whether it was hemolytic uremic syndrome or TTP, as I said, schistocytes will be present in both because same problem happening. فكمان نفس الشيء red blood cells will be cleaved off, it will present as schistocytes. بس in the clinical clinical question أو بالسيناريو that we will have, we need to differentiate whether it's HUS or TTP. But here I have mentioned the most important things for you to be able to differentiate them. First of all, the hemolytic uremic syndrome mainly occurs in children. And it's usually preceded by an infection with E. coli. And the type of E. coli is O157H7 in more than 90% of the cases. So whenever this child receives the E. coli, one of the manifestations of these E. coli is the hemorrhagic diarrhea. So the patient will have hemorrhagic diarrhea or the bloody diarrhea, abdominal pain, and it can be very severe that acute kidney injury can also occur. So because we have acute kidney injury, you will find an increase in the creatinine levels, severe increase in the creatinine levels. And this is very specific for the hemolytic uremic syndrome. And also due to the accumulation of the uremia, and these things. Another thing is that we have other causes that may cause hemolytic uremic syndrome, مو بس E. coli, which is like the Shiga toxin. And it is known as the Shiga toxin E. coli, but it is atypical, not very common, not like the E. coli. And the treatment, as I said, because we have acute kidney injury, the treatment will be dialysis and plasma exchange for severe persistent disease. An important thing in the hemolytic uremic syndrome is that we have absent neurological features. We don't have any neurological features, unlike the TTP or the pentad that we just explained. The TTP, it usually happens more in adults. It is associated with other immunological diseases, whether it is SLE, malignancy, or anything else. And we have the classic pentad, as we said, which is the fever, the acute kidney injury, the neurological manifestations. And here the neurological manifestations are very important because they're not present in the HUS. And the thrombocytopenia and the microangiopathic hemolytic anemia. From the pentad that I just explained, if you have 3 of these symptoms, then you need to suspect it. For the treatment in the TTP, we can also do plasma exchange. It is the best initial thing. And then we can give steroids if needed, but usually plasma exchange is enough. However, in the hemolytic uremic syndrome, kidneys are very affected. You have increased creatinine level. You have to do dialysis. You cannot delay it further. Okay. Finally, we have the heparin-induced thrombocytopenia. From its name, as we can see that it is a thrombocytopenia or decrease in the platelet count due to the usage of heparin. We know that heparin is an anticoagulant medication to prevent the blood clots. Let us explain first how this happens. Okay, so the main mechanism behind the development of the heparin-induced thrombocytopenia is actually an immune response. It starts whenever you take in heparin. This heparin binds to a protein. As you can see in this picture, it binds to a protein on the surface of the inactivated platelets called the platelet factor 4. Together, they form a complex called heparin platelet factor 4 complex. This complex is immunogenic in certain people, meaning they have circulating immunoglobulin G antibodies that will recognize it as a foreign pathogen, will mark it for the spleen to destruct it. So these for the destruction within the spleen. Now when the antibody binds, it causes the platelet to activate. This to activate the platelet, it will release procoagulant chemicals like the thromboxane A2, and that will causes further platelets to activate also. At the same time, the original, yes. So at that same time, the original platelet will also release more platelet factor 4, so more antibodies will bind and keep it activated. This event will lead to more and more platelets getting activated, and they start forming clots throughout the body. This way, a lot of the remaining platelets get also consumed, which results in a low platelet count. Normally, it generally takes a week for the body to make immunoglobulin G, physiologically, that target heparin factor 4 complex. That's why thrombocytopenia in these cases develop 1 to 2 weeks after the starting of the heparin therapy. So in the scenario, we'll have patient starts developing thrombocytopenia after 1 week from taking heparin. طبعا we have an exception to this is whenever the patient is already treated with heparin, so he already have the immunoglobulin G antibodies, فالheparin induced thrombocytopenia may develop within the first day of taking the heparin. This is an exception, it doesn't always happen. Okay, for the clinical picture, we have of course, as I said, cutaneous bleeding, mucosal bleeding, and if the platelet count is less than 50, 10,000, the bleeding after any procedure or surgery is very severe. If the platelet count is less than 10,000, then this is life-threatening. At that point, we can have intracranial hemorrhage or heavy GI bleeding. You need to differentiate the condition from any other coagulation disorder whereby we don't have bleeding into the tissue or the joints, so we have no hematomas or hemarthrosis like in the coagulation disorders. For the investigations that are done, we can, of course, we will find thrombocytopenia, decreased platelet counts. We can do the ELISA, serological assay to detect the immunoglobulin G antibodies. However, many individuals that have received heparin will have these antibodies. So not all of them will develop HIT, so the test will not be very specific. The more specific or the gold standard is the serotonin release assay. In the serotonin release assay, the patient's serum is mixed with heparin and with the donor platelets. The activated platelets will start releasing the serotonin. So in a positive test, the patient's serum will have antibodies that activate the platelets and the serotonin level will be very increased. But last thing, while you confirm the diagnosis, it's important to immediately stop the patient heparin and start with another anticoagulant, يعني a non-heparin anticoagulant. Example for that is the argatroban, which is a thrombin inhibitor. Also, we can give a platelet transfusion as necessary to the patient. If the patient has a thrombic event, anticoagulation is continued for 3 to 6 months. But if there was no thrombic event, then anticoagulation continues until the platelet count normalizes. That's it. We just have one question. Anyone would like to read it? Okay, thank you. Okay, what do you think is the answer? It is the first answer, which is the microthrombi in the small blood vessel. The reason behind this is that this is a case of hemolytic uremic syndrome. If you remember, in the hemolytic uremic syndrome, I mentioned something very important. Let's get back to it. Is that whenever it affects the children, the cause is the E. coli. So the patient will come with abdominal pain, bloody diarrhea, and acute kidney injury are seen. Maybe I should have put the normal values of the levels, but here also you can find that the creatinine is elevated. The platelets are low. So all these signs are that of the hemolytic uremic syndrome. Here's also a table of the hemolytic uremic syndrome, further clarifying the answer. As I said, it can be due to E. coli, and the patient will have anticipient bloody diarrhea. Patient will have anemia with the schistocytes. That's why her hemoglobin level is low. Thrombocytopenia, as we can see that in the scenario, also the platelet levels were very low, and acute kidney injury with the patient's creatinine level being very high. You said the second answer, which is the streptococcal antigen associated glomerular damage. Your answer, this is a post-streptococcal glomerulonephritis. Here's an explanation of it. يعني it's a totally different scenario, not related much to the bleeding and so on. يعني it follows a cutaneous or pharyngeal infection, and then it causes an immune response. يعني this immune response will cause a deposition in the glomerulus, so the patient will have oliguria, hematuria, proteinuria, edema, hypertension. There's nothing related to anemia or thrombocytopenia as يعني in our patient. Is it clear now? All right, thank you very much. If anyone have any questions, you can ask. All right, thank you everyone very much. We will move on to the next presentation. But if you don't mind, I would like to send a link that is not related to the attendance. It is more personal as I need it for the postgraduate purpose. If you can please fill it up. Thank you very much.
Okay, so is my screen clear?
Yes.
Thank you. Okay, so I'll explain for you vascular bleeding and disorder and antiplatelets drug. So sorry. Sorry for interruption. Is my screen clear now? Okay, so let's start by the vascular bleeding disorder. What is the problem in the vascular disorder? The problem is a defect in the vessels itself. The platelet cannot interact with the poor vessels. At the end, you will find there is bleeding. Usually, this disease characterized by easy bruising and spontaneous bleeding from small vessels. We have two causes for this disease: inherited vascular disease or acquired. For the inherited vascular disease, we have three types: hereditary hemorrhagic telangiectasis. This is the first one. Okay, this is an autosomal dominant disease. The mutation will be in the endothelial protein, and you will find there is a dilated microvascular swelling. The clinical feature will be telangiectasis developed in the skin, in the mucosa, in the internal organ. So if you see here in this picture, this is a small vascular lesion in the lips or in the mucosa. Okay. Second clinical manifestation will be recurrent epistaxis and gastrointestinal bleeding. Usually, patients with gastrointestinal bleeding will end by iron deficiency anemia because of this bleeding. So the treatment will be immobilization. With the meaning of immobilization, it's an invasive procedure. They use substance to block that bleeding, that vessels which have a bleeding. Okay. Then we can also use laser treatment or tranexamic acid. Tranexamic acid will inhibit the fibrolysis to decrease the bleeding. And also we can give iron supplement, okay? Why we give iron supplementation? As I mentioned before, this patient will suffer from iron deficiency anemia. In severe cases, GI bleeding, we will give the patient antivascular endothelial growth factor. The second disease called connective tissue disorder, which is also called Ehlers-Danlos syndrome. This is a collagen abnormality with a purpura resulting from difficult platelet adhesion. The clinical manifestation will be hyperextensibility of joint and hyperelastic fiber skin. And the second one, pseudoxanthoma elasticum, associated with atrial hemorrhage and thrombosis. What is the meaning of pseudoxanthoma elasticum? This is a progressive disorder characterized by accumulation of the deposition of calcium in the elastic fiber. As you know, the elastic fiber provides strength and flexibility of the structure. So when we have a problem here, the patient will suffer from the hyperextensibility, and as I mentioned before, and also it can affect the vessels itself and cause premature atherosclerosis. The other clinical feature will be superficial bruising and purpura, followed by minor trauma, or after you remove the tourniquet, you will see there is a purpura. Last, bleeding and poor wound healing after surgery. The third disease will be giant cavernous hemangioma. This is caused by chronic activation of coagulation, leading to laboratory feature of disseminated intravascular coagulation. And disseminated coagulation, intravascular coagulation, this disease, the blood clots are excessively produced in the body, okay, leading to aneurysm, and then the vessels will be ruptured. At the end, you will find there is a bleeding from everywhere, from ear, from nose, from mouth, from everywhere. Mm-hmm. Regarding to the acquired vascular defect, this is the second cause. The first one is simple easy bruising. This is a common benign disorder occur in healthy women, especially those with childbearing age. Senile purpura, this is a disease in old skin, in older patient. It occurs like rupture in the vessels, leading purpura. Usually you will find it in the dorsal aspect of the forearm and hand, as you see in this picture. Third one is purpura associated with infection. Fourth, Hinge purpura syndrome. Hinge purpura syndrome, this is the most important one in acquired vascular defect, usually seen in child, and this disease followed like acute upper respiratory tract infection. This disease also called IgA vasculitis. It can also lead to IgA nephropathy. How? When the infection affects the body, stimulation of IgA production will be increased, and the deposition of IgA immune complex will be in vessels wall. It can be deposit in the skin or GI tract or joint or kidney. Once it deposits in the kidney, this is will called IgA nephropathy. طيب, let's talk about the purpura itself. What is the characteristic of this purpura? We see in this picture on the right side, it's like accumulation, it's rush combined by localized edema. And itching is usually in the buttocks or in the extensor surface of the lower leg and elbow. Other symptoms, it will be like painful joint swelling, hematuria. Why hematuria? Because of IgA nephropathy, the patient will suffer from hematuria and abdominal pain. Secure via purpura, this is occur because of vitamin C deficiency. Defect collagen may be caused like perifollicular patches, small patches as you see in this picture, بتكون very small patches and bruising. Steroid purpura, from its name, it's associated with long-term use of steroid or with Cushing syndrome. As you know, the problem in Cushing syndrome is excessive production of steroid. So this patient will suffer from a purpura called steroid purpura. Here we have like an important information that tranexamic acid can't be used with patient have hematuria because it may lead to clot and obstructing the renal tract. Okay, so let's talk about the antiplatelet agents. We have three class. First one called an irreversible cyclooxygenase inhibitor. Okay. Drug like aspirin, acetylcyclic acid. What is the mechanism of action of this drug? How the aspirin works? If you see here in the right side, okay. When we have look too close to the platelet from inside, when platelet become activated, the arachidonic acid released from the membranous phospholipid, okay, this one. Then it will convert to prostaglandin H2 by COX-1. And then this prostaglandin H2 will metabolize to thromboxanase A2. After that, the platelet will release it to stimulate other. Any questions? Okay, so once this prostaglandin H2 metabolized to thromboxane A2, it will be released from the platelet to stimulate activation of a new platelet to promote aggregation. Okay, so aspirin will go and inhibit this COX-1. No platelet aggregation will occur. So what is the indication for this type of a drug? Acute myocardial infarction, acute ischemia, stroke, in angina, however stable or unstable, and management of atherosclerotic cardiovascular disease. What is the side effect for this drug? GI bleeding, ulcer, dyspepsia. You will find the bleeding time will be increased. However, the BTT will be normal. Also, like acute kidney injury, salicylate poisoning. Salicylate poisoning هو الactive form of aspirin. The last side effect called Dravet syndrome. This is very important side effect. Occur when the patient have like viral infection and you give this patient aspirin and also the patient age less than 90, you will find this patient will suffer from Dravet syndrome. which is like a type of hepatic encephalopathy. يعني رح تلاقي عنده symptoms للانسيفالوباثي. طب what is the contraindication? Febrile illness in the individual less than 90 and acute age attack, gout attack, sorry. Second class, okay. For people who study surgery now, this is very important information, like the platelet lifespan تبعها من 7 ل 10 days. So you should stop the aspirin before the surgery week away, okay? 1 week away. طيب the second class called P2Y12 receptor antagonist. The most common one called clopidogrel. How this drug works? It's also an platelet aggregation inhibitor. Work by blocking the action of ADP, okay, receptor specifically by 2Y12. As I mentioned before, activated platelet will release a chemical mediator, one of them called ADP, which bind to the P2Y12, leading to activation of glycoprotein 2P3A receptor, which are required for fibrin mediator platelet cross-linking. And so by blocking, this drug will block this receptor. So by blocking this P2Y12 ADP receptor, this drug effectiveness will inhibit the platelet aggregation and also the clot formation. طيب, what is the indication for this drug? In STEMI and also in unstable angina, non-STEMI patient, we can give the patient clopidogrel. The side effect will be allergy reaction, rash, and hemorrhage. Last class called glycoprotein 2A3A inhibitor. طيب, the most common one, apiximab. How this drug work? Okay, this drug inhibits the platelet aggregation by binding to the glycoprotein 2A and 2P and 3A. Okay, also prevent fibrinogen from binding to platelet and making them unable to cross-matching. Indication: prevention of a thrombotic complication in high-risk patient with unstable angina and in non-STEMI when we want to do PCI within 24 hours. Type, what is the side effect for this disease? Acute profound thrombocytopenia and hemorrhage. The contraindication: patient with thrombocytopenia less than 100,000. Okay, we have some question here. Okay, who would like to read, please?
I can.
أول شيء presentation واضح تبع الكويشن؟
لا.
طيب now
يعني الحين
Yes.
okay. Okay, please read something.
اوكي اقرا انا. تمام. A 5-year-old boy is brought to the physician by his parents because of 4-day history of arthralgia, abdominal pain, and lesion on his arms and legs. 10 days ago, he had an upper respiratory tract infection. A photograph of his right leg is shown. Further evaluation is most likely to show which of the following.
طيب, what do you think? أول شيء شو diagnosis؟
ممكن يموت ثرومبوسيتوبينيا بربرة. هينوكسوريا بربرة.
نعم.
هينوكسوريا بربرة.
Yes. طيب, what do you think شو رح نلاقي؟ Hematuria? Yes.
I would go for hematuria.
Yes.
ما بعرف.
صح. ليه هيماتويوريا؟ لأنه إحنا قلنا هذا البيشنت ممكن رح يكون عنده أي جي نفروباثي نفرايتس سيندروم، رايت؟ فرح يكون الواحد من السيمتومز هيماتويوريا. النيو هيرت ميرمر بنسمعها مع ديزيز لما بيكون في عندنا سبكتينوس بكتيريال اندوكاردايتس، بس السيمتومز كلها ما بتدل إنه هذا البيشنت عنده اندوكاردايتس. الكونجكتيفايتس بتكون مع الكawasaki ديزيز، وهذا مانو كawasaki ديزيز. وممكن السيمتومز اللي تشوفها بالكawasaki ديزيز يعني اللي بتدل انه هذا كawasaki ديزيز اللي هي الكونجكتيفايتس، لازم يكون في بالسيناريو كونجكتيفايتس. ثرومبوسايتوبينيا هي كانت مع دكتورة مها لما شرحت لكم إياها، كانت مع الهيموليتيك يوريميك سيندروم.
Nice. Okay.
Thank you. طيب we have other question. Who can read please? طيب okay I will read، بس بدي حدا يجاوب. طيب
A 45-year-old man come to the physician because of a 3-month history of recurrent headache. The headache are a dull, non-pulsating quality. The patient denies nausea, vomiting, and photophobia or photophobia. The neurological examination saw no abnormality. The physician prescribed a drug, irreversible inhibits COX-1 and COX-2 by covalent stylation. Which of the following medication was mostly likely prescribed by the physician? Aspirin, because aspirin is inhibit COX-1, which will inhibit the platelet aggregation.
yes, thank you.
Yeah, just I want to add something. As what my colleague said, as aspirin, and when aspirin is inhibit this, when the aspirin inhibit this amino acid, this when aspirin inhibit this enzyme, it will actually lead to accumulation some of the medicators and inflammation, and that with the chronic maybe that will lead to asthma.
Can you repeat please? Your voice wasn't clear.
Okay, now is it clear?
Yeah.
Okay. The answer as what my colleague will be B, because aspirin will inhibit this enzyme, and when inhibit this enzyme, that will lead to accumulation some of the medical inflammation mediators, interleukin 5, interleukin 6, and that with the time that maybe will lead to asthma.
Yes, thank you. Thank you. So any questions? That's the end. Thank you for listening.
Thank you very much.